Yeah, excellent. Well, thanks a lot for that introduction, Professor Prendergast, and thank you to both you and Michael for inviting me to give the talk today, and hi, Steve, of course. I've been asked to talk about the challenges and new frontiers in cardiac pathology. As you've heard, I work with Professor Shepherd. I had a PhD that was funded by CRI, and I'm currently a clinical lecturer funded by the NIHR. So I'm going to talk about some of the challenges and new frontiers. There are obviously quite a lot. I think one of the things that Professor Prendergast has just highlighted actually is the diagnostic variation that we see globally. So as you can see, there was variation in the amount of cardiomyopathies that were diagnosed from about almost 15% up to 50% in some of the studies, and also with SADS ranging from about 6% all the way up to about 55% in our study. So that's something I think that definitely needs addressing in the future. I'm also going to quickly talk and also show a study looking at some emerging novel entities, or one specific entity, but also talk about another entity as well. And I think one of the really important things about what we do is distinguishing acquired from genetic diseases. And actually, our understanding of this is not fully there yet. I think we don't necessarily, there's lots of entities that we kind of, in a way, don't suggest that we do screening for. And I wonder whether maybe there may be genetic causes or genetic contribution underlying some of these conditions. So I think that's something exciting to explore for the future, because of course, you definitely want to be highlighting where there is possible genetic disease, but you also definitely don't want to be missing out where there could be a possible genetic contribution in a disease as well. And then I think the role of genetic variation is another very important area that we need to understand in the development, particularly cardiac enlargement, but also its role in sudden cardiac death. So these are the international guidelines that we recently published with the AECVP, so that's our European group together. And pathology is very much a visual specialty. And of course, with visual specialties, there is great variation, and then guidelines tend to be quite subjective. So these guidelines that we produced actually don't necessarily have clear diagnostic criteria in them, and we haven't necessarily quite agreed on exactly what heart weights we should be using to determine whether something might be pathological or not. We don't necessarily talk about how much myocyte disarray or how much fibrosis is really relevant. We talk about it being there or it not being there. So I think quantifying this is something that's going to be really important. And on the right here, you can just see a couple of cases where there can be diagnostic difficulty for referring pathologists particularly. On the top there, you can see a case of arrhythmogenic cardiomyopathy where we have infiltrating fat and fibrosis. But on the bottom, you can see a case where we have considerable fat around the epicardials, on the epicardial surface, with infiltration into the right ventricle. But actually, this is essentially a normal heart, or just increased fat around the heart, and it's not arrhythmogenic cardiomyopathy, but it may be incorrectly diagnosed. So that's something that we highlighted within this paper as well. So just to move on to emerging novel entities, we've recently published on obesity cardiomyopathy, and we're trying to determine whether that is, essentially our future studies will look particularly to see whether this is just related to the obesity, or whether there may be underlying genetic factors, and we want to study families, following up the relatives, cardiologically screening them, and then also perform genetic analysis on the spleens that we have to see whether there may be a genetic contribution to this. And as I say, I think that's really important, because we don't want to be writing people off if there may be a genetic disease that could also be in family members as well. So I think other areas which are going to be really important for us to study are the potential role of drugs. Can there also be a genetic condition? Are there more than one factors that are at play within conditions also where you might have an alcohol cardiomyopathy? Is there a diabetic cardiomyopathy? I think that's another question we want to answer pathologically. Are we seeing fibrosis in these cases? Do we not see anything when we just have diabetes by itself? And another thing which I'm going to highlight a bit further is anorexia and its effect on the heart as well. So I think it's very important for us to study the role of these conditions within sudden cardiac death and their development of cardiac changes and also fibrosis. And again, I think the use of molecular autopsy to look at both variants that might underlie these conditions, but also polygenic risk, will be very important in the future. So this is a study that I've just recently conducted. It's in its early phases, where we looked at individuals with anorexia, which is an eating disorder characterized by low weight and food retention. And we know in this condition there's an increased risk of arrhythmia and also premature sudden cardiac death. And what we wanted to do was characterize the cardiac changes that we see in these individuals. We identified 97 cases where there was no other cause of death essentially found other than the heart being, so we didn't find any cause of death in these individuals at all. And anorexia was based either on the previous diagnosis being made or of a BMI of less than 17. And these were age and sex matched to normal hearts and from individuals of a normal weight. And this cohort was 33 years with a standard deviation of 16 years, and they were actually mainly female, which is very different. As you've seen earlier, the data that Raghav presented was that normally it's about a 2-to-1 ratio with males, and that may be explained by the incidence of anorexia within the two genders. And the weight in these individuals was 48 grams on average, and there was a BMI of 15. They had a significantly lower heart weight, so this was 54 grams less, and 50 grams with regards to cardiac pathology is quite a lot of weight, so it is significant. They had smaller right atrial and left atrial dimensions, a smaller left ventricular cavity, and they also had a smaller muscle wall on the lateral left ventricle. And one of the really interesting things that we saw in these cases is when we looked down the microscope, we could observe that there was necrosis within the fat. So here is just an example of an anorexic heart compared to the normal heart. You can see this kind of whitish appearance on the surface. And when we look down, so they also look smaller as well. But when we look down the microscope, on the right-hand side here, you can probably see that it looks slightly more pink. This is difficult to project. But as such, you've got a loss of all the fat, of all the normal fat, which you can see on the right-hand side here. And this is the fat actually dying on the outside. And this is something that has not been observed ever in the literature before. So we wonder whether this may play a role as such in these sudden cardiac deaths. And we also wonder whether the fact that the heart is smaller could play a role in these sudden cardiac deaths. And I think, again, it's going to be important to do genetic follow-up in these individuals to see whether we can detect anything on molecular autopsy. And we'll also see whether potentially by public health initiatives such as, and also increase the psychiatric healthcare might help these individuals and reduce the risk of sudden cardiac death in anorexic individuals. As I say, I think the also follow-up of family members may also help in these cases as well. So these are some of the future area. I think this is the future work, some of the areas that I think that we're going to focus on to answer some of these questions. So as I was saying, I think quantitative international guidelines for pathological diagnosis of cardiac conditions is going to be really important. I think we need to standardize it, not just in Europe, but also around the world, and then we'll have accurate comparison between the different countries. As I think we'll find that the incidence in SADS in other countries is going to significantly increase if we have reproducible guidelines. I think the role of all these conditions that I've talked about on the development in cardiac enlargement or indeed microcardia and their subsequent cardiac death will be very important to study. I want to start correlating what our findings are with the protein variants that underlie these conditions. And I also want to start a study of the variant negative populations to see whether we can detect anything in them, potentially whether there might be any environmental conditions that might play a role in there. And then I think one of the things that will be very important to standardize in pathology is the use of artificial intelligence and computational pathology. So essentially we'll scan our slides in and we can do digital quantitative analysis. And then we'll also look at spatial and single cell RNA analysis and also polygenic risk scores. I think it's going to be a really interesting thing for the future. So thank you very much for your attention. I'd like to thank everyone for